This portion of our presentation is going to lead us into listening to Dr. Kosnett, who's going to take us through an update on some lead and arsenic, new concerns about some ancient materials. This is going to phalanx quite well with the rest of our morning. So thank you very much, Dr. Kosnett. You know.
All right, great. It's a pleasure to join you all remotely. I'm here in Denver, Colorado, and I want to talk to you today about some relatively recent developments, if not in the science, at least in the general appreciation of some of the effects of two significant metals that we encounter both in environmental settings and in occupational settings, lead and arsenic. Now, to start with lead, most of you are aware that the most common clinical measurement that we use for lead is measuring it in blood. And this is an important perspective on what the OSHA standards are, which still are in existence in almost all states except two. And that is the OSHA standard requires or does require and says that people don't have to be removed from exposure until their blood leads exceed 50 micrograms per deciliter. Now, when the OSHA standard was established in the late 1970s, it was assumed that people who were entering the workplace would have a blood lead concentration in the high teens. And in fact, in the mid 1970s, the US geometric mean population for the entire population was 12.8 micrograms per deciliter. Today, because lead's been phased out over the past several decades and eliminated in gasoline and in fuel and in canned food, the levels are now less than 1. But an interesting thing that I want you to realize is that the experience of this population of people who spent many decades of their lives in the 1940s and 1950s, 1960s, 1970s with blood lead concentration in the teens is very relevant for what people are experiencing today in the workplace. Because although the general population levels have dropped by more than 95%, people who are working with lead, for example, 80% of the lead used in the United States is in lead batteries, those individuals are still exposed to lead in the teens. Now, when the OSHA standard was established, this is actually from the original Federal Register notice, they were talking about avoiding overt manifestations of lead poisoning. And this I won't read it, but this is some of the things it says, about changes in behavioral symptoms. It also talks about changes in motor nerve conduction velocities, renal insufficiency, things of that nature. What's missing from that is a very important thing. It's missing the contribution of lead to mortality. And studies started to emerge about 20 years ago that indicated that people who were exposed to lead in the teens or slightly higher had an increased risk of dying of cardiovascular disease. This is some data taken from the NHANES 2 study, which is a national representative survey of the US population. Back in the 70s and the 80s, it was conducted every 10 years. In recent decades, it's been conducted every 2 years and updated. And what it showed that individuals who had a blood lead concentration at onset of 10 to 19 and were followed, not for a long period of time, only about 12 years, had an increased risk of dying of heart disease. And this was after controlling for multiple different factors that are used in the NHANES study that are also risk factors potentially for cardiovascular disease. Now, a an update. What happened here? An update of this type of analysis was recently published by Bruce Lanphier and colleagues in Lancet in 2018. And what he did is he looked at NHANES 3, which is a next iteration of this study that was conducted on the general US population. Remember, these aren't lead workers. These are just general US population. Uh, you know, people who were um, participating and enrolled in the late 1980s through the early 1990s. And he followed them up for a mean of 19 years. Now, how did they know how what people died of who were participants in that NHANES survey? They check their vital status in the death index, and then they can get um, uh, death certificates for indicating the cause of death. And when they did this, after controlling for multiple other confounders associated with heart disease, was that the hazard ratio for dying of cardiovascular disease associated with changing the blood lead from 1 to 6.7 in this population in the late 1980s was an increase of 70% in the risk of dying of heart disease. And when you look at just ischemic heart disease, it was more than double. The hazard ratio was 2. Now, bear in mind that these individuals who were enrolled in at the beginning of that period of follow-up in the late 1980s, they had a blood lead of 1 to 6.7. But they were, or they had blood leads that were less than 10 for the most part. They lived a good proportion of their lives back in the 60s and the 70s when blood leads were in the teens. Another analysis that is a large prospective cohort study was the normative aging study. And the normative aging study was a study that was begun in the Boston area in 1963. And it looked at multiple different types of disease endpoints. And one of the things that they decided to start looking at in the 1990s was measurement of lead in bone using non-X-ray fluorescence, non-invasive K-X-ray fluorescence. That's a technique that an individual sits in front of a very low radiation beam. It gives you less than a single dental X-ray of radiation, and they can assess the concentration of lead in the bone. And it's a good biomarker of long-term lead exposure because the half-life of lead in bone is years to decades. And what they found, if you looked at ischemic heart disease deaths and you took the bottom tercile of this population with lead in bone as the reference point, the group that had the highest tercile had more than a 5-fold increased risk of dying of cardiovascular disease. And this is, again, after controlling for smoking, high cholesterol, um, body weight index, family history, all these other factors. Lead still emerged. And these people were a healthy population when they enrolled in the study, and they were not necessarily lead workers. They were teachers, they were clerical people, they were white collar and some blue collar workers, but they did not have, their exposure for the most part was just general population. And you can see here, these are some of the things that were adjusted for in the analysis. Now, a group of us in the early 2000s wrote a paper that has been cited fairly substantially, saying that, listen, we have to reevaluate what we consider to be an acceptable level of lead exposure, because here we're talking about death, an increased risk of death. You know, in many things in occupational health, we establish controls and we reduce exposures for subclinical things. If we find out that people have changes in their liver function tests at a certain degree of exposure to something in the workplace, we'll say we need to lower that level. If people have slight anemia, we want to lower the level of exposure. Here we're talking about dying. There's no more significant endpoint. And in this paper, we called for removing people um, from lead exposure if they were above 20 or 30 micrograms per deciliter, and maintaining a goal of keeping people's blood lead concentration less than 10 micrograms per deciliter. Oops. Um, and in 2011, the occupational health branch that dealt with lead poisoning, in particular in California, with support from the Western Occupational Environmental Medical Association, established an advisory committee to look at revising the California lead standards. And OSHA standards, the way that works in around the country is that states can establish stricter standards than federal OSHA standards, but they have to be at least as strict. So comments were submitted, and there was a process of getting this through the system. And in February of last year, California passed a much more stringent and, in fact, the most protective lead standard that I'm aware of in the world. Now, one of the goals of the California lead standards were to maintain blood lead concentrations less than 10 micrograms per deciliter, and to provide more protective medical removal protection. And I'll talk about that in a second. They also talked about revising and mandating the permissible exposure level for lead in air, which was 50 micrograms per cubic meter in 1978. They also talked about not relying on air monitoring alone to determine who needs medical surveillance. There was a concept introduced of just performing a certain amount of work with lead, independent necessarily of what was in the air, and then to apply basic hygiene measurements to all occupational lead exposure, not just people who are exposed above the permissible exposure level. Now, most of you are probably aware that under the current OSHA rules, the ones that were developed in the late 1970s, there was a progressive element that said that individuals had to be removed from airborne lead exposure when their blood lead concentration was elevated. And that was considered to be a single blood lead greater than 60, or the average of the last three greater than 50. And physicians were given a discretion to order this at any blood lead level based on their judgment that a worker was at a material health impairment. But generally, medical removal protection was not instituted for decades. The practice was not to institute it until people had blood leads greater than 50. Now, the new criteria for medical removal protection in the Cal-OSHA standards is a single blood lead level greater than 30, the last two blood lead levels greater than 20, and these are usually taken a month apart, or the average blood lead concentration in the last 6 months greater than 20, or a final determination of the physicians. And during medical removal protection, there's going to be monthly blood lead monitoring. There's going to be no work above the action level, which is now 2 instead of 30. No altering or disturbing lead materials that are greater than 0.5% or 5,000 parts per million lead by weight. And also, you can't do certain things like torch cutting any scrap metal or things of that nature. You can then return to work when 2 consecutive blood leads taken at least 30 days apart are less than 15. And if a patient, if a worker wishes to become pregnant or actually the standard says procreate a healthy child, which includes a male worker, they can place them at removal, for example, they can remove them from exposures that would be, uh, let's say, greater than 5 micrograms per deciliter. Now, the air monitoring levels and the permissible exposure level was reduced to 10 micrograms per cubic meter, and it had an action level of 2 micrograms per cubic meter. And then if you exceeded those action level of 2 micrograms per cubic meter, which is a substantial reduction, as you know, from 50 in the previous standard, you had to have increased exposure monitoring. And then also there was the hierarchy of controls that were necessary above the PEL of 10, including providing appropriate PPE. Now, the other thing that I mentioned is that many times lead exposure can occur even though the air monitoring might not demonstrate that the level of lead in air was above the action level. For example, one of the patients that I once evaluated with a blood lead level of 60 worked in a retail establishment where he was polishing brass. It was a place where they sold a lot of brass urns and plates and decorative items. And he was his job was to polish the brass, and he seemed to do a lot of that in the back room when he was having his lunch. And he had a lead level of 60. There was no elevated air levels. So now the Cal-OSHA General Industry Standard says that if you're doing a presumed significant amount of work with lead, which is altering or disturbing, as I mentioned, the lead standard would apply to you. And most importantly, I think, overall, is that whenever an employee has a blood lead greater than 10, the employer has to establish and implement a written elevated program for that employee, which describes specific means that they'll use to lower their blood lead concentration. What is FedOSHA going to do? In 2022, FedOSHA issued an advance notice of proposed rulemaking to seek input. ACOM issued a position statement and comments, and you can find out a lot of the details about it in the March 2023 JOEM that basically supported the California standard and said maybe even go stricter than that. Now, I want to leave you before we move on to arsenic with a key point, and that the Cal-OSHA rules for lead, in my opinion, have now set a new standard of care for occupational medicine physicians on how they should approach lead workers or people exposed to lead. And you have the ability, even if you don't live in California and you're not covered by California standards, under current OSHA standards, they explicitly allow physicians to order medical removal at a blood lead concentration necessary to protect a worker from, quote, experiencing material health impairment from exposure to lead. And I believe and recommend to you that Cal-OSHA standards should guide how all occupational physicians make decisions now regarding lead workers. Remember here, we're talking about the most serious endpoint possible for an occupational exposure, and that is an increased risk of dying. And the risk applies to the disease, cardiovascular disease, that is very prevalent in society. So the actual number of workers who would be affected by this risk would be substantial. All right, let's move on in the remaining time. Who knows what these pictures are of? These are pictures of people who've been exposed to very high levels of arsenic in drinking water. This is hyperkeratosis of the feet, of the palms. This is a gentleman I took a picture of in West Bengal with his permission, and he has a freckled hyperpigmentation on his chest. People there normally aren't freckled in that part of the world. And this is Blackfoot disease or peripheral vascular disease. And this comes from being exposed to levels of lead, levels of arsenic generally in the range of 500 to 1,000 micrograms a day by ingestion. And we don't have, generally speaking, it's only with rare exceptions, do we have that high a level of arsenic in drinking water in the United States. But we do have a lot of areas where there is naturally occurring elevations of arsenic in drinking water. We also have some other potential exposure of certain drinking water aquifers to leachate from coal fly ash impoundments, where that coal fly ash contains elevated levels of arsenic. And then I list here some other things where people can get elevated exposure. Some of you may have heard about the fact that rice and infant rice cereals contain elevated levels of arsenic. And that's for reasons being that the rice plant tends to concentrate arsenic to a certain extent. Occupationally, we have people who are working in copper and lead and zinc smelting who are exposed to arsenic. We have some use of arsenic in the gallium arsenide semiconductor manufacturing process. The only real herbicide use of arsenic that is allowed is monosodium arsenate, which is used on certain golf courses and turf applications. There is still arsenic wood preservatives that are allowed in industrial applications, but no longer allowed in residential applications or like outdoor playground equipment or decks. Now, the EPA standard for arsenic in drinking water for many decades, beginning in the 1940s, was 50 micrograms per deciliter. And then, and in 1993, EPA, mainly relying on some epidemiological data from Southwest Taiwan, where there were high levels of arsenic in drinking water and well water naturally occurring, established a reference dose for arsenic of 0.3 micrograms per kilogram per day, or and a cancer slope factor of 1.5 per milligram per kilogram per day. And this was based just on the risk of skin cancer. In 1999 and 2001, the National Academy of Science had a subcommittee on arsenic in drinking water, which I participated in both these committees, and we recommended prompt reduction because there was a risk of not just skin cancer, but also lung and bladder cancer for ingesting arsenic. And in 2001, EPA reduced the maximum contaminant level to 10, but it didn't revise the cancer slope factor, which really governs a lot of the decisions on cleanup of arsenic at hazardous waste sites or remediation of other situations where there's environmental contamination. Interestingly, this at the time in 2001, we estimated on this committee that if they reduced the drinking water standard to 10, there would still be an excess risk of lung cancer after lifetime exposure at 1 in 300. Well, what's the newest punchline? In January of 2025, EPA issued new reference doses and cancer slope factors for arsenic. And you can see here, for example, this is taken from that report. This is arsenic intake in micrograms per kilogram per day, and this is lung cancer excess risk. This is the mean estimate of the slope of the relationship, and this is the 95% upper bound. And what do we come up with? We come up with cancer slope factors that the combined risk for bladder and cancer, the slope factor is 31.7. The old or the former IRIS slope factor was 1.5. So you can see it's gone up substantially. And this will really change what's considered to be cleanup standards around the United States. Now, they also did some calculations of the current level of arsenic permitted in drinking water, the maximum contaminant level of 10 micrograms per liter. And they found that if you look at the combined cancer risks at that level, they're 41 per 10,000, or 1 in 243. That is much higher than our historical goals in the United States and in the public health community for protecting people from an excess risk of cancer from an environmental exposure. Normally, the acceptable range is considered 1 in 10,000 to 1 in a million. So even now, our current knowledge now about the risks of arsenic-induced cancer and the potency of it is such that even what we would consider acceptable levels under the standards of arsenic in drinking water are far from being protective. But it gets even worse. EPA analyzed additional epidemiological studies. They conducted a meta-analysis, and they show that arsenic is also associated with an increased risk of dying or just having ischemic heart disease or diabetes. And so they lowered the reference dose to 0.6. And finally, in my last slide here, I wanted to show you one thing. This is at the current maximum contaminant level for arsenic in water plus dietary intake. And these are lifetime extra risks per 10,000 individuals. Remember, we said the normal goal for public health protection for cancer is 1 in 10,000. These are based on the mean estimates of cases, not on the 95% upper bound. But you see here that you have bladder cancer about 8 per 10,000, lung cancer 10 per 10,000. Ischemic heart disease and diabetes are about an order of magnitude higher number of excess cases. Why is that? Well, remember, excess cases is the relative risk -1 times the background rate. And the background rate of having ischemic heart disease and diabetes is higher than the background risk of lung cancer and bladder cancer. And that's why this case differential. But it really drives home the point, and the take-home message is that arsenic is a really major issue with respect to environmental contamination, and that the levels we've established up until now to protect us from our arsenic in water and in environmental media are not protecting us to traditional standards of protection. Thanks very much. I can take some questions.
Fascinating, Dr. Kosnett. I see Nalene in the chat wrote, "This is very timely for me as I had a locksmith with concerns yesterday about lead exposure. Only using a simple face mask for respiratory protection. Will likely need a regular monitoring program that was previously not in place."
Yes. I think that, again, my take-home message for you there is that the OSHA standards, we've known that the OSHA standards haven't been protected for a long time. I don't think a lot of the people who work with lead or the people who are supervising them realize that the risk of dying from cardiovascular disease associated with blood lead in the teens is as high, it's on a par with the risk associated with hypertension, high cholesterol, and smoking. Now, we all exert a lot of education and public health activity to control blood pressure, cholesterol, and get people to stop smoking. The risk of occupational lead exposure is equal to that in terms of increasing your risk of dying. It has to, this has to cause a whole new paradigm on how we're dealing with lead exposure. That's a,
Agreed.
and
Rajaram wrote, go ahead. Go ahead.
one other thing to bear in mind, the data on the things I've shown you today about arsenic and lead, they're human epidemiological studies. They're high quality. They're cohort studies, prospective cohort studies, or in the case of arsenic, case control studies. They're not based on big extrapolations from animal studies. Uh, this is the highest quality evidence that you can bring to bear on creating a cause and effect relationship applied to lead and arsenic. So these things I'm telling you are very solid.
Indeed. Do you have any comments about industries or occupations that will have the greatest challenges for meeting these new lead guidelines? And thank you for an excellent talk. That's from
Thank
Nick
you.
Wright.
Well, 80% or of the lead used in the United States is in storage batteries, lead acid batteries, both in transportation and cars and in things like uninterrupted power supplies. And they've they've been on notice for a while that they're going to have to lower their standards. And there was opposition to this in California when this was finally brought forward. Um, but I think that they've been put on notice about it, and that they will be able to adapt to it. There are some lead recycling and smelting facilities that can meet this standard right today. Uh, I think that we have to also realize that there's a lot of lead um, that is present in old housing and old residential buildings. And there's a lot of people who have their homes remodeled, and painters and carpenters and other people who are doing demolition or remodeling. And those people may not realize the risk that they're facing. And I think there is a EPA renovation and remodeling program that requires that the people who are doing this kind of work have to follow certain standards of protection. But I think that the enforcement and awareness of those rules needs to be enhanced.
I can personally attest in Baltimore, just the scale of infrastructure updates to meet some of this it's unimaginable. A lot of the city schools, potable water is provided by water bottle. It's been this way for a couple years because the amount of infrastructure updating is incredible. Someone wrote, do we have any idea why these metals increase the risk of CAD?
Of coronary artery disease?
That's what I'm assuming the acronym is.
Yeah, yeah. Probably it's due to they cause oxidative stress, both lead and arsenic, and they cause inflammation. And we know that oxidative stress and inflammation contributes to cardiovascular disease, and that's one of the thoughts of the mechanisms by which they increase cardiovascular disease. We know.
Understood. Understood. Were you going to go on?
No, I'm just saying there's also animal models for lead uh, that show that, like, if you give lead to animals, whether it's mice or dogs or rabbits, they develop high blood pressure. And they have effects on their vasculature. And, obviously, we don't rely on animal studies, actually, because humans are more sensitive to lead than in animals. And in arsenic, what's interesting is that there's no really good animal model of arsenic causing cancer, but clearly humans are are the most sensitive organism to arsenic-induced cancer. And one of the thoughts is that humans don't really have as much fur, right? We don't have as much hair as most animals, like other mammals, right? And arsenic binds very strongly to keratin, and it may be that for other species, there's they shift they shift the arsenic into keratin or other sources and yeah, other binding sites, and they don't have the same vulnerability. But that can't totally explain it. But humans are clearly the most sensitive um, animal species for susceptibility to arsenic.
Katerina posed the question, why do you think it's all being overlooked, Dr. Kosnett?
Well, I think that relatively speaking, it's new, but it's in the past 20 years, okay? But it sometimes takes a while. It takes awareness. And folks like us who are on this call and who are practicing occupational environmental medicine, we need to be at the forefront of creating awareness. You can't, we're at a time where you can't rely on necessarily thinking that just because there's a standard that exists, that standard is protective. The standards follow the science. They don't precede the science. So we now know the science has changed, and we have to advocate for changes in standards and also advocate for changes in awareness. The uh, California is the biggest economy of any state in the country. It's the eighth largest economy in the world, uh, and they can do it, and they will do it. By the way, they did a cost benefit analysis weighing the costs of implementing it to the benefits that would accrue from decreasing cardiovascular disease, and it was very, very cost effective in the modeling to protect it. So I hope we can. I hope that when you leave here, that you're aware of these two major changes and changes the paradigm thinking about how we're going to deal with what we consider acceptable exposure to lead and arsenic.
Right. Jeremy had wrote, great presentation. I'm thinking about LMIC countries where displaced camps are set up. How long would the skin effects from arsenic take to be visible?
The skin of the dermal effects generally hyperpigmentation. It's somewhat dose dependent. At the levels that we see with arsenic in the United States, I mean, people exposed, to generally the average person in the United States, the background level without having elevated arsenic in the diet is 6 micrograms per day, about. And if you were, um, drinking arsenic at the maximum contaminant level of 10 micrograms per liter, you would, have, somewhere around 10 micrograms per day. You don't get skin lesions at that level. Okay. You have to have arsenic uh, exposure to many hundreds, greater than 500 micrograms per day, generally speaking, uh, to to see skin lesions develop. And the hyperpigmentation takes about 5 years. The hyperkeratosis takes about 10 or 20 years.
Thank you. And one last one from Romero. Are there any consequences from an exposure standpoint in this regard that are potentially being created when someone is trying to seek LEED certification, for example? I'm wondering if, as we're trying to be more environmentally sustainable, if there are any unintentional exposures in this arena that could be created.
Say the LEED certification, they said, for buildings. Is that what
Yes,
it is?
yes.
I'm not sure if I understand the question. I think that um, I think that when we do, Romero, do you want to
Yes, sure.
elaborate on that?
Thank you, Dr. Kosnett. Yeah, I was just the question I was trying to ask is, as we're trying to be more environmentally sustainable and so forth, in this arena, um, if as we're trying to do that and the materials that we're using, are there certain sort of unintentional cases or case examples, even in these aspects of lead or arsenic that we may need to look out for, or something that just based on the materials that we are being using to try to be more environmentally sustainable?
Well, that's a good point. I see what you're saying.
Yeah,
We have to make sure that the substitutes that we come forward with uh, for things like lead
yeah,
um, don't have their own problems. I mean,
right,
we don't want to start using,
right.
uh, if you're starting getting like lead, not using lead pigments, but we're using cadmium pigments. Well, that's not
Mhm.
a
Right,
solution. Or if we're
right,
using
right.
manganese
Mhm. Yeah,
instead of lead, we have to be careful about that. Yeah. Um, Lead's not unique in that situation when we make product substitutions, and uh, we have to keep a mindset to that, and we also have to keep a mindset that it it can take large studies over a long period of time to sometimes evaluate this. The reason we know that lead causes this cardiovascular disease is not from studying people in the workplace. There
right.
are a couple of SMR studies of workers that show that there's elevation, but there's only like one or two,
Mhm.
of risk of cardiovascular disease. There's only like one or two studies. One of
Right,
the reasons that we found it is that we had this general population of all of us being exposed to lead levels in the teens. Well, not those of you who were born after 1980, but people like me who were born before that, my lead level in the when I was growing up was 15, and and if your parents were alive at that time, that's what their lead levels were. And knowing from these large prospective cohort studies, which were already established, not to study lead, but just to study health in general, we were able to go back and make this finding.
right, right,
It's not easy. We were fortunate in lead to pick it up. In the case of arsenic, there are places in some parts of the world where there are naturally occurring elevated levels of arsenic. And by studying those and doing a meta analysis and bringing in thousands of cases, we were
right,
able to show these relationships.
right.
But
Thank
for many things that are introduced, you're absolutely right. New things that are introduced, we may not have that data.
Right, right. Thank you so much, Dr. Kosnett.
Thank you.
Well, it's fantastic. Is there any other questions or comments for Dr. Kosnett? Thank you very much for that.
You're welcome.